Greetings, I'm Dr. Park Jung-chul. Going to talk about when to place the implant after extraction and look at various cases. As you experience more, you gain more trust among your patients. Let's begin. In the previous lecture, I talked about placement period and using extraction socket to determine when to place the implant. The different category of socket was done using Alien's classification. And based on that criteria, I'm going to talk about how implant treatment is going to be provided for each category using clinical cases. Treatment planning after extraction, you can divide that into three. First is the immediate implantation. Second is the period may vary, but it is delayed placement. And third is there's socket preservation. You prep the surgical site and wait. These are the three ways. Type 1. There is no bone resorption and no soft tissue resorption, and lesion is only in the apical area. Therefore, in type 1, so all three options are good. Let's look at immediate implantation case. In number 21, there was fracture and mobility. If you look at the X-ray image, in number 21, on the root, there is horizontal fracture. This is a type 1 immediate implantation case. Based on my experience, more than other options, immediate implantation leads to best results. If you do immediate implantation, you need to minimize damage to adjacent tissue, and you need to be very careful with extraction. The soft tissue and bone loss and the extraction socket can be minimized, and the surrounding tissue can be preserved, and also can get aesthetic implant treatment results. This is the extracted tooth. 2 millimeter or more space is needed buccally, and the implant has been placed palatally. On the day of surgery, temporization was provided. On the day of surgery, this is the CT. Implant was placed palatally, and there is sufficient space with buccal bone. This is when the treatment was complete. The soft tissue shape could have been better, but this is a typical type 1 immediate implant placement case. And in the case of upper anterior, high aesthetic demands exist, and immediate implantation after extraction, you can maintain and preserve tissue and satisfy such aesthetic demands. This is CT after completion. Compared with the day of the placement, buccally, there's a little bit of resorption, but there's still 2 millimeter of buccal bone for implant support. Type 1 delayed placement. Let's look at that case. In number 47, there was a vertical fracture. On the X-ray, mesially, there was vertical fracture. There's a little bit of distance with inferior alveolar bone. However, it is not sufficient, so I chose delayed implantation. Extraction was done. Extraction socket shape, there was no damage, and it's sound socket, so I didn't do anything else, and I just waited. This is after 3 months. Soft tissue healing is very nicely done. On the X-ray image, its bone is not fully filled, in the socket, but it's okay. If you open flap, you can see certain level of bone fill. And there's no major difficulty in placing implant. One-stage surgery was done, and so in the distal area, there was a little bit of bone defect, and bone graft was done. After implant placement, this is the X-ray. There was a certain level of bone fill. There was not a lot of stress in placing the implant, and it was placed in a relatively favorable position. This is after treatment. You can see that there's balance between the surgical site and adjacent tissue. And this is after implanted treatment. Type 1, third method was used, the socket preservation in this case. And this is the X-ray when the patient came in for scaling. And after a while, number 46 was fractured and the patient came in. Extraction was done. It was a young female patient and she had a lot of fear about implant surgery. Immediate implantation would have been nice, but that was not done and delayed placement was chosen. So when implant was going to be placed in order to make surgery more easier, I explained to the patient that socket preservation was needed. Xenograft was used. Collagen plug was used. And socket preservation was done. This is 2 weeks later and suture was removed. The healing is nicely done. This is after 1 month. Luckily, there's a little bit of bone loss in the socket. After 4 months and 2 weeks after extraction, approximately 18 weeks later, implant was placed. In the extraction socket, there was bone fill and it was very easy in getting the implant position and doing surgery. Initial stability was nice and a one-stage surgery was done. This is the final prosthesis. This is approximately 10 months after extraction, and this is when the treatment was completed. Approximately 1 year, 6 months later, this is the X-ray. You can see that the bone around the implant is well maintained. In type 1, when you do immediate implantation and in delayed placement and socket preservation, the 3 cases were shared. In sound socket, regardless of which method you choose, you can get relatively nice treatment results. Bone resorption level may differ depending on the case, but if there's just a bone loss and no atrophy of the soft tissue, and this is frequently observed in diseased socket. In the case of type 2, immediate implantation, delayed implantation, and socket preservation can be done. And I'll explain this by showing you the cases. In type 2 immediate implantation case, number 34, 35, 36. It was originally splinted and there were crowns. However, there was mobility. And that was the chief complaint. Crown were removed and teeth were re-evaluated. There were mobility in the teeth and extraction was planned. After crown was removed, this is the patient mouth. There's not a lot of soft tissue resorption. This is after extraction. After implant placement, in number 34 and 35, there is buccal bone loss, and in number 36, there is distal resorption. The socket shape was rather sound and there was no soft tissue atrophy, so it was not an easy immediate implantation case, but there were no major obstacles. In the case there's bone defect, you need to do bone graft, and if there's resorption in the bone wall, you can use membranes. When you do immediate implantation and connect the healing abutment, you can use the membrane and do bone graft. In those cases, you call this a transmucosal GBR. In the case of immediate implantation, you can use this for bone defects. Suture is done and surgery was complete. This is X-ray image after implant placement. In number 34, there was buccal bone loss, and number 36, there was bone defect in the distal root. And using the membrane, bone graft was done, and this is the X-ray image. After implant placement 4 months later, the treatment was complete. This is patient visit after treatment completion. In number 34, there is not a lot of buccal bone loss in the X-ray image, but in the distal bone loss in number 36, you can see that bone is growing in. I'm going to talk about delayed placement and type 2 now. In number 46, buccally, you can see cyst coming out. On the X-ray image, on the mesial root, there was severe lesion, so extraction, and implant treatment was decided. This is after extraction. Buccally, there was a lot of bone destruction, and I thought it would be difficult to get initial stability for immediate implantation, so delayed placement was decided. In this case, regarding how long you should wait, it may differ depending on the case, but in this case, I decided to wait for 4 months. The reason is because the way the socket was destroyed, bone graft was imperative in implant placement. Therefore, when implant was to be placed, soft tissue to cover the surgical site was necessary, so we decided to wait for healing, and there was a lot of bone loss buccally, and if there was bone fill in the socket, it would be more favorable in finding the position for the implant placement and for initial stability, so we waited 4 months. Because there was a lot of buccal bone loss, the contour of the socket may be reduced, but because there were teeth in number 45 and 47, so overall the bone arch shape, I thought it will not be affected severely, and the GBR could be used to restore the shape of the socket. And this is after 10 days after extraction. 4 months later, implant was placed. As you can see, there's a lot of bone resorption buccally. So on the buccal side of the fixture, there's only a very thin bone left, but fixture exposure was not observed. Xenograft was grafted and 2-stage surgery was completed. Implant was placed, and this is the X-ray image after that. 4 months later, at secondary surgery, you can see that the buccal bone, which was severely resorbed, there's a lot of bone regenerated, and you can see that the buccal bone has been regenerated after treatment. This is the patient mouth. Panoramic image. This is after treatment at the end of July. If you look at CT, buccally, the bone graft is not fully maturated, and you can still see bone graft, but after 1 year at follow-up, the bone graft on the buccal side, you can see that it has regenerated into a normal bone. Next is socket preservation for type 2. As you can see, As you can see, there was root fracture mesially and there was a lot of bone loss and extraction was decided. This is patient mouth. On x-ray image, bone resorption was very severe, but soft tissue resorption has not occurred. On the x-ray image, I've shown you the bone loss was very severe, so immediate implantation will not be easy. Delayed placement should be done. However, in this state, if you just wait, there will be a lot of resorption of soft tissue and there will not be a lot of bone fill. So I thought it'll be difficult to place implant later. Therefore, socket preservation and implant placement was planned. This is after extraction, and within the socket you can see a lot of bone loss, and buccally there was bone loss as well. In this case, non-resorbable membrane and xenograft was used to do socket preservation. If you can get primary closure, it's not easy to get primary closure in this extraction site. It is not easy to cover the extraction socket with soft tissue entirely. I used non-resorbable membrane and used open membrane technique, or you can also use open healing technique where you use resorbable membrane. On the image, it looks like I got some primary closure, but the extraction socket, the soft tissue, I think it will open up. This is after 2 weeks and suture was removed. You can see non-resorbable membrane has been exposed. If you can sterilize it every day, it'll be ideal, but if that's not possible, it's okay to do it every 2 to 3 days. And if you plan open membrane technique as you do socket preservation, you need to explain to your patient ahead about what could happen, and the patient needs to understand fully that the membrane can be exposed. You need to make the patient understand that this is not a problem. This is after 5 weeks. And you can see a larger dehiscence has been formed in open membrane technique. If you can maintain the membrane for a long time, that'll be ideal. At least you need to maintain 3 to 4 weeks. This is at 5 weeks, and membrane margin was starting to be exposed. So I removed the membrane, and this is after. There was no infection. Below the membrane, you can see that the soft tissue has filled in, and the graft, it looks a little bit exposed, but you don't need to remove it. You can just sterilize it and observe it. This is after 4 months. You can see that the socket has healed nicely. This is image after implant placement. The destroyed socket, it has healed nicely and volume is well maintained. You would be able to place your implant easily. However, the bone in the socket looks like woven bone. So you should do under drilling and do drilling as you do an autogenous bone to get initial stability and place the implant. Initial stability was approximately 30 Newton centimeters, so 1-stage surgery was done. If you look at the X-ray image, the socket, which was severely resorbed, the bone has regenerated well and the implant was appropriately placed. 3 months after implant placement and 7 months after socket preservation, treatment was completed. Soft tissue volume has not been reduced significantly. There's appropriate balance with adjacent tissue. This is X-ray image after completion. This is a CT at the time of socket preservation. There's a lot of bone deficiency. This is after 7 months when treatment was completed, CT image. The graft, which was filled the defect, you can see ossification being progressed. This is 15 months later. You can still see ossification. However, the bone regeneration is rather stable now. At the time of extraction, there was a lot of bone destruction. However, with socket preservation and if you do site preparation appropriately, you can do implant treatment in a very stable manner. Next, let's look at type 3 socket according to Allianz classification. It is similar to type 2 socket, however, it is the most difficult to treat and you need to restore the soft tissue lost. In the case of type 3, you can also consider immediate implantation, delayed placement, and socket preservation. First, let's look at immediate implantation. On the image in number 46, there is furcation involvement. If you look at patient mouth, soft tissue resorption has occurred, and because of tooth mobility, extraction and implant treatment was planned. The reason I chose immediate implantation because on the X-ray image, alveolar bone resorption is not very severe, and if you look after extraction buccally, there's gingival resorption buccally, but in the area where alveolar bone was resorbed, epithelialized granulation tissue exists. In tooth with mobility, if there is soft tissue resorption, frequently, there's epithelialized granulation tissue within the socket, and if you use this very well, and you can use this to replace the lost soft tissue. The epithelialized granulation tissue dissected and form a buccal flap, and after you open flap, if you look, alveolar bone was not severely resorbed. And implant placement, there's no major difficulty. After implant was placed, you can see a little bit of thread exposure here. Xenograft was grafted, and as I mentioned, the transmucosal GBR was done. This is after suture. The epithelialized granulation tissue in the socket, it replaces the buccal gingival loss. X-ray image after surgery, 1 week later, and when suture was removed. The epithelialized granulation tissue. It will later heal into a keratinized tissue. 9 weeks later, abutment was connected. On the buccal side, epithelialized granulation tissue, you can see that it has turned into keratinized tissue, and the atrophied gingiva, it's healing nicely. This is the panoramic image. In the patient mouth, you saw the balance with the adjacent alveolar bone was nicely managed. In type 3 socket, if you do immediate implantation, it's not easy to do this. However, if you choose the appropriate case, this is not impossible. Next, I'm going to talk about the delayed placement in type 3 socket. In number 46, there's furcation involvement. If you look at patient mouth, buccal gingiva is resorbed. After extraction, within the socket, more so than the radiographic image, there's a lot of bone loss and soft tissue loss buccally is observed. In order to do implant treatment for this patient, I explained that bone graft was necessary and the patient felt stressed and the patient could not make a decision. We did extraction and we waited and decided to take our time in making a decision. After extraction, this is 1 week later, and already buccally, the volume is much reduced. 1 month later, buccal volume is resorbed a lot, and when there's bone loss as well as gingival resorption, the socket size becomes reduced very quickly. After 3 months, the patient decided on an implant treatment and implant surgery was decided. Buccally, there is bone loss. However, in the socket, you can see a bit of bone fill. Implant was placed, and on the buccal side, dehiscence defect is observed. Transmucosal GBR was done and bone graft was done. There's dehiscence buccally, however, in number 45 and 47, alveolar bone is well maintained and the contour of buccal bone will be able to be restored. This is after suture and after abutment connection. Alveolar bone has healed and buccally, in the area where there was a gingival resorption, you can see that it has been restored. This is after 4 months prosthesis delivery. The soft tissue volume which was lost has been restored a lot. In this case, relatively, the alveolar bone and the gingival loss, it was restored favorably. However, you can see that there was a significant change in socket volume. When there's both bone loss as well as gingival loss, and if you do nothing after extraction, in doing implant surgery, it may require a lot of advanced technique, so you need to prepare starting from extraction. In type 3, bone loss and buccolingually, there's also gingival resorption. In this case, depending on how you treat the extraction socket, it will have very significant impact on implant treatment. Immediate implantation is not easy in this case, so I normally do socket preservation. Let's look at a case. In number 16, mesial root and palatal root, there's a lot of vertical bone loss and it's very close to the sinus. In number 17, vertical bone resorption is observed. If you look at the patient mouth, in number 16, buccally, there is gingival loss. However, in number 17, there is no gingival atrophy. Palatally, in number 16, there is gingival loss. In number 17, there isn't. In number 16, it can be considered as type 3 in Alien classification, and there's bone and soft tissue loss buccolingually, and in number 17, it can be classified as type 2. The treatment plan involved extraction of number 16, 17, and 18, and considering the relation with the sinus, immediate implant placement was not possible, and in the case of delayed placement, it would have led to significant loss of adjacent tissue around the socket, so socket preservation and implant placement was planned. This is after extraction. If you look mesially, in number 16, buccomesial root and the palatal root. Within the extraction socket, there's epithelialized granulation tissue. As mentioned earlier, mesially and palatally, there's, if you include the epithelialized tissue in the flap, And you can use that to replace the soft tissue that is lacking. Dissect it and use it. In this patient, there is septal bone, and you can assume that there will be very nice bone regeneration. Xenograft and resorbable membrane was used, and socket preservation was done. Suture was done. When you do suture, you should use various matrix suture for flap approximation. That'll be favorable. This is the day after surgery. And the blood clots that has been formed, if you maintain it well, soft tissue healing will be done nicely. This is after 2 weeks when suture was removed. You can see nice soft tissue healing. After 3 months, you can see a little bit of bone graft. However, this is not an issue, and just remove the particles using forceps. This is 18 weeks later, and this is the patient mouth when implant was to be placed. The socket preservation was done, and you can see that soft tissue healing is done nicely. When you open flap, the socket which was destroyed, you can see that healing has been done nicely. In number 16, where there was severe destruction, you can see nice bone healing. If there's nice socket healing, it is easy to place implant. And initial stability was approximately 25 newtons centimeter, so 1 stage surgery was done. For this patient, there was a lot of keratinized tissue, so Plauchi technique was used. This was for secondary healing in between implants. Flap was covered. This was done to encourage healing. And this is after suture, after implant placement. 5 months later, final prosthesis was delivered and treatment was completed. After implant treatment, 6 months later, this is panoramic image at follow-up. Socket preservation was done nicely, and the balance with the adjacent tissue is very nice, and it will lead to good long-term prognosis. Let's summarize. Ilian's extraction classification can be divided into type 1 sound socket, type 2 bone resorption, and type 3 socket with both bone and soft tissue resorption. And depending on the classification, I talked about how to come up with implant treatment plans. Implant treatment after extractions, the strategy can be divided into largely 3. Whether you do immediate implantation, delayed implantation, or whether you do socket preservation and then do implant placement. I've talked about clinical cases that fall into these 3 categories. You need to be fully prepared when you are about to do something. This is the same for implant placement as well. I talked about the implant placement period and strategy, and I've shown you multiple cases, and I hope this helps in you getting good, successful implant placement. Thank you.
고맙습니다.